Good evening, everyone. My topic is fast track simultaneous bilateral TKR. Actually, this is a very debatable topic, and due to medico legal issues associated and the insurance issues associated. I'm Colonel Santosh, retired 14 years of service in armed forces, and then I'm doing my second inning in Medanta Hospital. And as you all are doing, I'm also fortifying the joint replacement and revision procedures for past 8 to 10 years. This is my first case when I was deputed as head of department Udhampur Command Hospital. I wanted to discuss, the aim of my topic is to make you understand about the need of the bilateral TKR, and hopefully I'll be able to convey my message to you all. So this is my first case. I did, he has participated in 1965 and 71R, and I did around 6 years back, and he's in touch with me, and he's doing very well. So what is bilateral TKR? And the fast track is when you are operating a case and discharging in 24 to 48 hours, it is fast track always. So bilateral TKR, the styles are staged or are simultaneous. Staged, the same stay which is popularly called as staggered, and second stay where we are calling our patient in days and months. Another things is simultaneous, where I was used to do along with my mentor, Dr. Vikas Kuchesta, concurrent, where I was used to do without tourniquet, and before tourniquet, the two team were doing concurrent simultaneous bilateral TKR. And for the cementing, we were inflating my sites. Then nowadays, I'm doing sequential TKR in Medanta, and I've did around 30 to 40 cases, and no infection, no complication I've noted. So if you'll see the history and all, these are the pioneer of the bilateral TKR. They published the data of 41 patients, where they found a stable less loosening and all, but only the problem was the infection rate was higher in bilateral TKR in earlier publication. You will see, when you will see the 1985 McLaughlin studies, where he studies the simultaneous versus the staged versus staged in days and months, and he found that the best result is with the simultaneous TKR. And one issue is with all journals is your data is not comparable. The primary TKR, the unilateral TKR can never be compared with the bilateral TKR. If you're comparing a bilateral TKR, you should double the complication of unilateral TKR, then it is justified. And when you see those way, it is always beneficial. But again, I'll come to a later stage. So if you see the major studies, there was no, published in JBG's 2003 and 2005, if you'll see those studies, simultaneous bilateral TKR has no significant difference in this study. The most common cardiopulmonary risk complications were lesser. And if you see almost all the studies, except Dr. Parvizi, who shows increased rate of mortality in bilateral TKR, rest of the studies shows no significant difference. Later on, the bilateral TKR volume started rising, and these are the JBGS publications only, which shows increased, where Dr. Parvizi's also increased rate of mortality, cardiac and pulmonary complications were higher in the bilateral TKR. If I'll discuss about the, to make you understand about the staggered, sequential and stage, if you'll see this study of Sliva, published in 2005, staggered was found to be good, and 3-4 days in the same hospitalization, they are doing this with the lesser complication. If you'll see this study, you will find that sequential TKR is having very high risk, high rate of complications. But if you read all about this study, the major complications of cardiopulmonary as associated in bilateral TKR is very less in sequential TKR. So what is the issue when we are doing bilateral TKR? The embolic, it is an embolic disease. I heard from my mentor that they were reaming the femoral canal, and it was cannulated reamer, and they were passing the feeding tube to suck out the fat cells. But now also whenever we are reaming a femoral canal, one side we are reaming, definitely we are sending something to the right atrium, risk of pulmonary complications and all associated. When you are doing both sides, definitely it is higher. But for that, there are precautions. There are always the things which can be done. If you will see our own study where we studied 3,160 patients, out of these patients, some were lost in the study and uh, some were given unfit from the anesthesia side. And we studied 1,200 on each arm, unilateral versus bilateral, and we found the mortality rate was higher in bilateral simultaneous TKR. These studies were concurrently. So what do you think? Would you take this risk with the high risk of mortality and cardiovascular complications? But definitely you will not try to take risk. But definitely there are indications. Indications are hard for bilateral TKR. Patient used to ask about the pain, increased functions and all those answers should be given by we surgeons. But definitely with the worst case scenario, the indications is non-ambulant, big deformity. If you give these patients unilateral, they will come with the loosening of the implant. And I have noticed in my cases, even Medanta 3-4 cases I have found, I'm not telling that surgeon has failed. Even the patients never come up for the second stage, the other side in a staged. So this is my one case where she came to me for the left side unsatisfied knee. She was not able to climb stairs, even on horizontal surface, she was not able to walk. I offered her to go for the right side, and immediately when I joined Medanta, this was one of the first case. I used to give, this is 3 hours post-surgery. She was able to do SLR, and post-operative evening she was walking. And presently, after 3-4 months, she started giving me on WhatsApp. Her husband was sending that she is walking for 3-4 kilometers in a park. So this shows the need for the bilateral TKR. A bedridden patient, her husband brought to me for make her come out of the bed, the room, and sit in dining room, and we operated both sides together after optimization, and she came after 1 year with the back pain. Husband is still not satisfied because he is moving around all around, not residing in the house. And this is my first case where I screened the patient, a diabetic, obese patient, bilateral TKR was given. This is the pre-operative, and this is post-operative evening she was walking. So definitely, what is the conclusion of my talk? Bilateral TKR is technically feasible. It is having a low complications rate, and it is always economically advantageous. Although there are legal issues, there are things which should be covered by the patient, surgeon, but prior risk screening and optimization is required. And regarding the improved outcome, the pain part of the patients, it can be always given a good counseling, rehab, pre and post rehab, everything should be explained, and patient can go for a bilateral TKR. Thank you for the listening. And in last, I want to add that we are adding life, but this life should be with a smile. So always screen your patient, go for the bilateral TKR. That was my aim, and hopefully I would have covered. Thank you for.
Well, Dr. Santosh, a few questions. You drape both the knees to at the initially stage only, or after doing the first you drape the second one?
No, we are having bilateral knee drape. It is available.
Okay.
So we are draping, and one side we are covering, and again we are painting.
And for the second knee instruments, the same instruments which are used in the first one is being used, or the new autoclaved instruments are being used?
No, same things same instrument where we.
Same instruments used. And tourniquet both side or no tourniquet?
Tourniquet one side, other side we are starting. I'm starting without tourniquet, and after 10 minutes of the tourniquet is closed, I am closing other side, the one side, and when I'm coming to the other side, is starting the incision, and later on inflating the wound.
So nowadays there is no role of tourniquet in TKR basis. Many people do only for cementing tourniquet.
Definitely.
The less you use tourniquet, more easily you can do bilateral sequential TKR. So that all the problem of cardiopulmonary is due to tourniquet per se, not due to TKR per se. Because when you release the tourniquet, then all the reactive oxygen is
Definitely.
So if you remove tourniquet from your surgery, you can do easily bilateral sequential
Definitely.
TKR.
When I was doing concurrent TKR, I used to do with my patient, when I was lagging behind with my mentor, but definitely at the time of cementing, my tourniquet was inflated.
Dr.
So,
Santosh, so with this bilateral concurrent TKR or in the same sitting that you do you have any criteria to screen the patient as to who is fit?
definitely, I forgot to paste that every surgeon is having their own checklist. We are having a 12-point checklist where we see the obesity, more than 2 comorbidities.
Because the
If
last
patient-
case you showed us was patient having diabetes and obesity, where I would have serious
It was definitely,
reservations
definitely.
doing bilateral.
It was extended indication, as I told. She was so, everything was concealed to the patient, and I'm working. Even her hemoglobin was 11. So prior to admission that day, 24 hours prior to the admission, we did withdraw her blood and given auto transfusion next day, Hemaxil the same day, and next day after DKR, we transfuse. And definitely there is a criteria, we all are having, we know that more than 2 comorbidities we should not go. More than 1 comorbidity we should be cross finger, our finger should be
Obesity
crossed.
is quite a high risk for a lot of post-operative complications. And I would say that TKR is a surgery which is to improve the quality of life. So putting life at risk would not be imperative. So that would be the message I would like to give to the house.
That is what I have told. It is our call, because in such cases, what I have shown, you can see these type of cases where the deformity is very much. I've received many patients with the loosening. Patient can be optimized, can be prior screening can be done, and definitely we are having hemoglobin should be more than 12. We are having checklist. The comorbidity should not be more than 1 comorbidities. All those should be kept in mind. And definitely we can opt, because I have received 3 patients. 3 patients I have received with the loosening on the one side. Patient, I'm not telling it is surgeon fault. Maybe he's not been convinced enough that you should come after 3 weeks, 2 weeks, whatever time the surgeon would have given.
I have also seen that the outcomes, OMAC score, IKD score of one knee which was operated gradually gets worsened because this other knee is not operated and all the weight is being
That
put
is
on
what-
the normal limb.
that is what-
So problem is not with the surgery, problem is the patient selection. So all patients can't go for bilateral TKRs, and it's not that no patient can go with bilateral TKRs. So you have to choose the patient carefully.
Definitely. Thank you.
Next talk is by Dr. Ashish Singh. He'll be talking on the impact of technology on success of joint replacement.